Bentrovati alla terza tavola del nostro appuntamento. La mia presentazione, come sapete, avviene in italiano per dare il benvenuto a tutti i partecipanti e amici che ovviamente ci seguono dall'Italia. Tantissimi sono però ovviamente le persone interessate dall'Europa e quindi la tavola proseguirà in lingua inglese, così come è stato pensato tutto il meeting dedicato alla sindrome E.E.C. Oggi 26 novembre 2020. Questa tavola è fondamentale non solo per i pazienti ma anche per i genitori, perché spesso i pazienti sono piccoli pazienti e quindi l'expertise dei chirurghi e di tutti coloro che si occuperanno della struttura proprio ossea e della qualità quindi di vita che da questo ne scaturisce, devono essere non soltanto di nostra fiducia, ma devono essere scelti tra i centri di massima responsabilità in Europa e noi li abbiamo a Padova. Quindi do il benvenuto al professor Bassetto e ovviamente passo la parola alla vicepresidente dottoressa Giulia Volpato, la quale porterà avanti questa terza tavola dedicata alla chirurgia e all'ortodonzia. Buona visione a tutti e attendiamo le vostre domande online.
Good morning, good afternoon to all of you, and really it's a pleasure to have with us this afternoon my surgery, so our doctor, that is Franco Bassetto, the director of the plastic surgery of the Padua University Hospital. Professore, I give you the word, the presentation.
Okay. Thank you very much, Julia. Good afternoon to everyone. Now we begin to speak about the role of plastic surgery in the holistic treatment of E.E.C syndrome. We know that with the E.E.C women, the extradactyly ectodermal dysplasia associated with cleft palate that it's a rare disease that has different aspects. Considering that for ectrodactyly women, the presence of different malformation, especially at the hand and at the foot. For ectodermal dysplasia, we mean something that is related to the embryologic development, and the cleft palate is the explication of the result of this ectodermal dysplasia. It's a polygenic inheritance in which the main rule is of the P63 gene that has the main mutation. So there are different syndromes with pattern of mutation related to the E.E.C with similar clinical presentation. The most common, but we have to consider it a rare disease, is the E.E.C syndrome. But you can see here other very, very rare aspects that are called with other acronyms and with other names in the whole scheme of rare disease, the E.E.C, the E.C.P, the lead, and so on. But for people, which is what is the multiple organ involvement? It's the skin involvement, the eye involvement, the hands involvement, the feet involvement, the lips, and the teeth. So these are the main location of the malformation that we will treat. Why the plastic surgeon is a key surgeon in this rare disease? because the plastic surgeon has in his DNA and knowledge the capacity to restore morphology and function. That it's very important, not only the aspect, but even and in sometimes at the first place the function. When the plastic surgeon begin his surgical projects, depending on pathology and the technique that he decides to apply. Most of the time, it's important to begin the surgical plan no later than when the patients enter in the school, and we will see why. How the plastic surgeon can have this key rule? Because he can use reconstructive surgery from simplest to the most sophisticated techniques, even considering the microsurgery at the highest level. What we mean with morphological and functional restoration of the malformation related to the E.E. syndrome, the possibility to get an aesthetically acceptable result. This is very important for the social rule that we can have in the social life of our young and family patient, for our young patients and his family. The other important point is to get the highest functional results that it's possible. And then we have to consider that in simple cases, in simple malformation, and we will see many examples of it, we can focus our attention on the morphological results. But in most complex cases, functional results are the first focus and the first endpoint. What is the surgery, the time for surgery? As I told before early, it depends on the case and the condition of the child. But we know that if we begin our surgical plan, we can have the best results if we can begin at around 8 months year old. Why? Because early surgery can has a very important results, especially in case of bone involvement, because if we act at this age, we can avoid the extreme deviation that we can have during the growth of the child. And in such case, we know that especially at bone level, we can have a worsening of the clinical case. The other target, speaking about time, is try to end surgery before the age school. Why? Because the beginning of age school, I mean 5 or 6 year old, in these 5-6 years, we have the best possibility to obtain the best result from brain plasticity. And brain plasticity is very important because it permits to change the image of the body, the image of the hand, the image of the feet at the brain level of our young patient. Speaking detailedly about the rule of plastic surgery, we can have different techniques that must be adapted to the different malformation. We speak of tailored surgery. One of the most important things that characterize the plastic surgery approach is that the plastic surgeon can adopt different techniques to different clinical case, changing his approach from patient to patients. This is called tailored surgery. And for this reason, it's very important a huge clinical examination to understand anatomy that it's under this malformation. The other very important point in the plan is to consider the imaging, and we will see in our patients how important is, for example, the X-ray or other radiological imaging. Then the planning of the surgery, that it's not to plan the first step of surgery, but all the project from the beginning till the end. And then it's very important to consider the rehabilitation, that it's not only physical, but it's even psychological, and considering which will be the role of the family in the follow-up of our family. And it's very, very important. Here you can see that now, especially in young we can use the magnification of our anatomy and our surgery using loupes or using the surgical microscope that now permit to us to be more accurate in our surgical approach for achieving the best possible results. Okay, so the rule of plastic surgery in reconstruction and correction of hand malformation. We have to consider that in ectrodactyly we can have at the level of the hand, considering the central aplasia that was in the terminal and embryological development, the causes of the malformation. For central aplasia, we mean the partial or complete absence of the median ray, which can be the clinical setting, clinical malformation at the hand level, the syndactyly, the cleft hand, and the oligodactyly. And we will see our patient treated with these three kinds of malformation, of different malformation. This is the cleft hand. For cleft hand, we mean different, we can see here 6 different cases, different appears of this malformation. We can have several patterns of presentation from mild to severe form. And for this reason, the result in function of the hand can be very, very different. We have to consider that the most important case that need a very huge approach is the functionless hands. For functionless hands, we mean a hand that has no possibility of pinch. In such case, we must consider this a very, very important malformation, and we have to reconstruct the possibility to have a pinch in this functionless hand. Here you can see which kind of help we can have from imaging. You see, for example, that in these cleft hands, both cleft hands, we can have different pattern of bone malformation. And the surgery here was developed through plastic surgery with plastic flaps that you can see here for a quadrilateral flap on the dorsal part of the hand and the zetaplasty that continue on the volar part of the hand. But from the beginning, we decide to remove these 2 bones for achieving the best 3-ray hand that permit the pinch for our little child. The other very important pattern of malformation in E.E.C syndrome is the presence of syndactyly. What do we mean with syndactyly? The fusion the digit fusion, that it's not only a soft tissue fusion, but can be even bone fusion. For this reason, we classified the syndactyly at different level of gravity. We can have a complete and incomplete soft tissue syndactyly with or without the presence of bony union. And even the bony union can be simple, complex, or complicated. This is the reason why at the beginning I told to you that the plastic surgery approach is called tailored. So we adapt our knowledge to the different clinics and to the different complicated cases at different findings. And then the third very huge, this is the hugest and severe case of pattern of E.E.C. It's the oligodactyly. Unfortunately, these no complete maturation of the long digits and of the first ray, it's don't permit to these patients to use this hand. So we can have fewer than 5 fingers. Here you can see 4 fingers. Here you can see 5 absence of fingers. This kind of malformation can be at the same time at the feet, and we will see other cases of different findings at the level of the feet. In any case, if we don't have digital elements, we need to restore them for achieving at least a B-digital approach, B-digital possibility to touch and to use the grip for having a normal functionality at that hand. Consider that this hand has no functionality because there is no ray that we can opponent to the first ray. Coming back to the surgery of these 2 main aspects of the E.E.C. syndrome at the level of the hand. The syndactyly. The objective of surgery in syndactyly is the morphological restoration and the functional restoration. In simple cases, the restoration has principal cosmetic objective, and this permits a good relationship of the child and the family. So this surgery has a social support, and we need to perform it speaking with the family that the objective is a social objective for a normal life of our patients. In case in other case in which we can have 2 different syndactylia, we can consider that at the end we will have a correct use of the hand, and this will avoid psychological disaster in our child, in the family, and in the social life of our patients. But if we have more dysfunctional findings like here, in which we have a 2-ray hand with no possibility of a good pinch, we must consider to remove this malformation, this malformated ray with no presence of the complete development of the 3rd and the 4th ray, and plastic surgery can restore them. Here you can see a very elegant result that was obtained with the transfer of the second digits of the foot in a patient that has only the malformation at the level of the hand, no foot malformation. In such case, the foot is the bank from what we can obtain the second ray at the right foot and the second ray at the other foot, obtaining with microsurgery. This is a very huge operation, 8 years of surgery with microscope. We can obtain a good pinch in all our hands. And this is very important to prevent the involution, the brain involution in using hand. For this reason, it's important to project this very, very difficult surgery that needs a specific and super specialist knowledge of plastic surgery and hand surgery at the age of 5 or 6 years old. In such case, we will have a psychomotor development that we can consider normal. When I spoke before about the planning of surgery, plastic surgery use the pen to sign the malformation and to, like an architect, to design his surgery. Here you can see the reconstruction of a the division and reconstruction of a web space in case of syndactyly. Here with a quadrilateral flap, here with a rhomboid flap and other 3 triangular flaps that will permit to have a good web space that we will see in our patients. Here you can see the plan, the drawing of another kind of surgery that through multiple zetaplasty we permit an opening of this web space, and this is the end of the patients with the incisions. And here you can see the planning of the surgery for a huge syndactyly to divide the soft tissue, volar at the volar plate, at the volar level, and at the dorsal level. And so we plan our drawing with a blue pen before beginning surgery. The design, a quadrilateral flap, zetaplasty on the volar aspect, this one, and from this planning and this pre-op imaging, our surgical work go on with a perfect surgical plan. This is very important. For this reason, the most experted surgeon of the E.E.C is related to the surgical planning, and that there is the technique part that it's related to other members of the group of the surgical E.E.C. Here you can see that we can have different surgery that depends on different level of complexity. Here we have not only syndactyly, but maybe we have a bone fusion at this level. So this surgery is completely different from this surgery, in which syndactyly is an incomplete syndactyly related only to soft tissue. So this surgery is simpler related to this surgery. This surgery is 1 hour consuming. This surgery maybe is 2 hours consuming. The correction of simple incomplete syndactyly like his, it's a 45-minute surgery consuming. Here you see on the volar side the quadrilateral flap that will permit the reconstruction of the web space, and here is the drawing on the volar the volar aspect. This surgery will be 30 minutes, 45 minutes of work in the operating room. And this is the final result, the final of the surgery. You see the flap, the quadrilateral flap advanced, and you can see after 1 year which kind of quality we can obtain with a completely open web space and with a completely good scar results. In multiple complete syndactyly, the surgery is more complex, as I told before, because we can have bone fusion. And this bone fusion is very important to be detected before beginning surgery. You can see here the fusion. So this is the plan at different level. And here is the complex surgery that we perform in 3 hours of surgery, obtaining this kind of result that at 1 year of follow-up is, in our opinion, a good result, cosmetically and functionally for the growth and for the brain image of the hand of this our child that is growing. In case of cleft hand, the cleft hand correction is more complex. We have many techniques that providing moving and harmonization of the digital elements operating to soft and bone tissue, and nowadays using microsurgery. Microsurgery with loops or the microscope permit to have a best approach to the little structures, I mean nerves, artery, venous, muscles, ligaments, and so on, for having the best result at the hand. And you can see a cleft hand correction that was performed in a 3 hours surgery consuming procedure with a good result, a 4-hand ray hands, that this was at the birth, the clinical case, and this was the surgery performed at 2 years, when the child was 2 years old. Or in such case, that is a very huge case of oligodactyly, unfortunately, we have only 1 ray. So we need microsurgery. And these, if you see, if you look at this new ray that was developed, we perform this operation with a group of friends of mine from Germany, Professor Wünster, that it's a very famous child microsurgeon that is guest of my institute 2-3 times per year. We performed this operation with the translation of the second finger of the foot to have this pinch that permits this movement, a quite normal life, a quite normal brain aspect of the pinch in this little child that has, unfortunately, this malformation at the birth. And this is another patient. This is Julia. I know that she allows to us to use her image, her surgical image. Julia arrives when she was not still a young a child. She was a beautiful teenager, and she decided to improve the scar retraction. That is something that the patient maintain for all their life due to the scar. So what can do plastic surgery after the growth of our child, of our young patients? It can develop a better scaring here with in time. Unfortunately, you see only the post-op that we had 1 month after the zetaplasty operation, but it permits to avoid the scar retraction that the patients can have, to improve his possibility to use in a normal way his three digital elements. But the plastic surgeon can have a correct approach even to the foot. This is the reason why we suggest to the family to choose a center in which plastic surgeon works in a perfect multidisciplinary approach with maxillofacial surgeon, with orthopedic surgeons, because even the foot can need a correction of the malformation. And we can see here an operation that we performed in a patient that was in contact with the Italian organization founded by Giulia in Padova. This is a child that arrived from Naples, if I remember well, and he had unfortunately this deviation that was related to the fact that the correction was done in child. So the growth, as I told before, unfortunately gave this not good evolution of the deviation of the ray, and we decided to correct with a bone subtraction and using plates to obtain this linear correction of the bone of the thumb. This permit of the first digit of the foot, and this permit to our young, he was 18, 20, if I remember well, to wear normal shoes. That is very important, especially for young people that like to use gym shoes. And this is another patient that arrived to our attention in this condition. Can we do something for her? Surely. We can improve the fourth ray. We can improve the web space. We can improve, if she needs, the aspects of this syndactylia not corrected, and we can improve the rhino image, the nose projection. And now I know that she is thinking if she wants to go on. Unfortunately, when she was a child, she was corrected only of the cleft labial malformation, but and maybe she was performed to operation to the first web space. But now she is 20, if I remember well. We can do more for her if she decides to improve her aspect from the cosmetic and functional point of view. And what we can do for this kind of malformation, we can do a lot. We can restore, for example, this digital part that is very important for the pinch, but we need to have a first or second digit that we can transfer. Unfortunately, for these patients that has a malformation, even to the teeth, we can't perform this microsurgery transfer, and we can't reconstruct the first ray. So the plastic surgeon must speak in a clear way to the patient and to the family, because we can have limits in our planning by the anatomy that we have in front of us, especially if the anatomy has these huge malformations. But the plastic surgeon has, as I told at the beginning, an holistic vision of these E.E.C. patients. why we speak of holistic vision? Because we know that the plastic surgery have a very important role even in the correction and the reconstruction of cleft lip and palate malformation. We can have different level of malformation. In case of central aplasia, we can have minimal or incomplete malformation that don't require extensive surgery, and we will see some patients treated. In case of central aplasia with complete clefts, we have the problem of bone gap, but with the bone transfer, the bone transfer from, for example, another part of the body, spinal area, and so on, we can obtain good restoration even of the bone aplasia. But in most huge cases, in hugest cases in which we have central aplasia with bilateral clefts, this case may require 2 stages, but nowadays our group prefer to perform everything in 1 stage repair. And we can see minimal aplasia with good correction 2 years after, the good correction, the good appearance of the cleft lip, and the good appearance of scars. Or in this that it's a little bit more important aplasia, the results and the evolution from the birth till the 6 years old evolution follow-up, in which the quality of scar improves spontaneously with a very acceptable asset. Or in case in incomplete aplasia, the surgery that was performed was more complex, arriving to this first result with the need of a second lip reconstruction with this follow-up 2 years after. In case of incomplete aplasia, we can need in a second time a correction of the scar at the level of premaxilla, a correction of the scar at the level of the lip, and a correction of the no projection. You see that this nose has no projection. It was a flat nose. And here you can see what we can obtain. This patient now it's 20. This is the follow-up after the correction even of the tip projection of the nose with a cartilage split. So this is very, very important to plan surgery from the beginning till the end with little possibility, with little surgery that can improve our final result. Plastic surgeon is never at the end of his job, and he consider every time the possibility to add some more little surgery to improve the final results. And here you can see the highest case of bilateral clefts that now we try to correct with the bone transplant and the reconstruction that can obtain this kind of result. Unfortunately, we have no good appearance of the lip, and unfortunately we have a flat premaxilla with no presence of the 2 rings that are very important for the cosmetic appearance of this area. And here you can see another case that was treated by Professor Tullio Jacopetti, that was one of my mentors in such case of surgery. The final results with, at the end, a non-acceptable, from my point of view, final result. We can suggest to this patient other surgery that can improve the line of the lip, that can improve the presence of the philtrum, that can improve, again, the shape of the tip of the nose, that it's now projected. If we compare this image with this image, but the quality of this tip is not the best in our opinion. So in other term, when we go to plan the correction of the schisis at the level of the face, we need a multidisciplinary approach, because we have to consider the good talking and hearing of our patients. So we need to work with the ENT specialist and with the speech therapist specialist. We need a good approach to skeletal development and teething, so we need to work in a multidisciplinary approach with the maxillofacial surgeon, with the orthodontist, and with the dentist. And last but not the least, the psychological development with a good relationship with the psychologist, and in some cases, unfortunately, even with the psychiatrist, where the patient has a body image disorder. But which is the end point of the fascial approach of the plastic surgery to E.E.C. That the palate must be continent, the hard palate must be without any fistulas, and the soft palate must be as long as possible. So we have to obtain an anteroposterior elongation, and in terms of mobilization, we have to recover the muscular function of the soft palate. And this is another patient that maybe somebody recognize. It is part of our historical images. This patient has the soft and the bone palate cleft, and this was the correction that was done on the soft palate, and then of the huge restoration of the bone, and so the hard palate, the bone palate, and the soft palate behind. The correction of the cleft lip and palate intervention ideally must be a restoration of shape without scar. But it's very important to speak with the family, because sometimes the expectations are higher than the reality that surgery can obtain. So we have to consider that if at the end we only will have visible scar, we must consider this result accepted. But if we will have distorted shape, we must consider this result as normal. We must consider it an abnormal result. We must refuse it, and we have to consider the patients, like the patient that we have seen previously, and the family, to go on with the possibility to obtain a better result with other surgery. And we can see here Julia again, that asked us to improve the presence of this part of her maxilla. This was, in our opinion, a good result, but we could obtain a better result. And we can see with a very simple surgery that correct with zetaplasty, the no mobilization that especially in speeching the premaxilla can have, and using the lipofilling, that is a simple aspiration of adipose tissue, 10 cc from the abdomen, we can obtain immediately, you can see, a very important improvement of the shape of the lip, and again, the presence of this very important column of the premaxilla that you can see in the lateral view. Unfortunately, this adipose tissue sometimes appear till 70% of its immediately result. And you can see here that the result must be considered still good, but it was not so good as after 1 week, after 2 weeks. Maybe these patients, Julia, has a reabsorption of the lipofilling about of 30%, but especially in the lateral view, you can see that the result of the lip and the result of the premaxilla is good, but from my point of view, we can propose to her another lipofilling to obtain another amelioration of the final aspect. This is another example. This patient has at the end of his premaxilla and central cleft palate malformation a good result, but he arrived to my consultation, and I told to him, you don't have to accept this nose because you can see that you don't have a good shape of your tip, nose tip. You don't have a good shape of your angle from the nose and for the premaxilla. And so I convinced him to a rhinoseptoplasty. And you can see here how the nose changed in terms of shape and in terms, especially here, of projection of the tip. And this is not a 7 days, it's a 7 months follow-up. This maybe can be considered, especially in a male that has the barbs that cover the scars, can be considered a final and definitively good result. Or even in such guys that I convinced to do again surgery for having an improving of the dorsum and the nasolabial angle. You can see after a rhinoplasty that was performed through an open approach, we obtain a really important improvement of this angle and a real improvement of the dorsal aspect of his nose and of his tip. Even this can be considered a final result. Now I am satisfied about all the surgery that we performed in these patients. Even in a girl, in a nice girl, why accept this? This card can be considered good. The projection of premaxilla can be considered good. The philtrum reconstruction can be considered good, but the tip no, and the rhino no. For the reason we performed a rhinoseptoplasty using even the cartilage from the ear to obtain a better projection of the tip of this nose. And this another not good nose. And for this reason, I insisted with this young girl that accepted his philtrum. We agree that the quality of the lip, the quality of the scar was good. So we suggest to her only a surgery to develop a better shape of the nose. And you can see how was the result in this more feminine and gentle nose in these young women. So for concluding, the multidisciplinary approach is important, and the rule of plastic surgery that has the possibility to do a complete plan for the treatment of the face, of the nose, of the premaxilla, the palate, the hand, the feet, and not only is mandatory. Plastic surgery provides several surgical solutions to different body area, hands, lips, food, and to all the body. What is very important is that we can have major plastic surgery procedures of 6, 7, 8 hours, like microsurgery of transfers of digital ray from the foot to the hand. But we can have even short and very simple surgery, like lipofilling on like scar revision, that can obtain very, very good results from the cosmetic final vision of our patients and its social life.
Sorry, Prof, we are finishing our time, so if you can conclude, we have a few questions also for you.
The final is that the environment, family, society interaction together may guarantee the best clinical results. But for having this very good result, you need a good group like mine. This is all my group that is working in rare disease, even in rare disease in plastic surgery. Thank you very much.
Thank you so much, and sorry for the interaction, but we have really a few times yet. So we are receiving a lot of questions about plastic surgery, but we can do only one to you now, and the others will receive an answer in, as always, in our Facebook web page. So Roberta?
Yes, thank you, Giulia. The question is, in patient with E.E.C syndrome, is breast reconstruction considered a syndrome-related treatment? In what case can it be performed?
It depends, because if the breast malformation is related to the genetic, we can consider the difference pattern of breast malformation related to the embryologic development related to the P63 malformation. In such case, we can do a very carefully clinical exams to the breast, to the gland, to the subcutaneous layer, to the muscle, and in such case we can do the correction, we can do the improvement of the shape of the dimension of the shape using prosthesis, using flaps, and we can have many different techniques to improve the aspect. The other very important thing is that we have two breasts in female. So what we need to obtain is the symmetry and the harmonious shape of them.
Thank you so much, Professor Franco Bassetto, and hope to see you soon personally.
Okay, thank you very much to you.
Thank you very much.
So we can go on with Dottoressa Piacentile from the Craniofacial Center of Vicenza. Dottoressa, please go on.
Hello to everyone. Thank you for this invitation to inviting my center to share our experience on cleft and craniofacial malformations. Our center is based in Vicenza, Italy. It is part of the maxillofacial surgery unit directed by Dr. Ugo Baccigliero, and it has been recognized as a regional, national, and European level, being part of the European Reference Network for Craniofacial Anomalies. I'll go on with my presentation.
You can share the screen.
Okay. So thank you again for inviting me to share our experience. This webinar is very important because In Europe, about 30 million people are affected by rare diseases. And E.E.C. in particular is a very rare syndrome because there are only 300 cases described in literature. And all patients deserve and need the best information available and the best treatment options available. So information need to be accessible. A quick recap on E.E.C. syndrome. Extensively, my colleagues have described the syndrome before. So we have an autosomal dominant disorder. It's characterized by three main signs, as you may see: ectrodactyly, the missing central ray of hands or feet; ectodermal dysplasia, at least one sign of it; and cleft lip and palate with always present. It is subdivided in three subgroups based on genetics, and the P3 gene is a mutation that causes the third group. So we can actually out TP63 related disorder, as the mutation in TP63 responsible for at least 5 syndromes and 2 non-syndromic human disorders, among which you may see isolated cleft lip and palate. So P63 has a crucial role in craniofacial development and pathogenesis of orofacial clefting. So in the literature looking for it, we have a review of over 230 cases in which they have calculated the frequency of the three signs. As you may see, ectrodactyly, an 84%, ectodermal dysplasia, 77%, and cleft lip and palate accounting for 68% of patients among the 230, and other anomalies. So in these patients, the percent of cleft lip and palate has been established among 60 and 75, and half of them have a bilateral cleft lip and palate, and only 10% an isolated cleft palate. But what is important that an E.E.C. patient with cleft will undergo the same treatment protocol as other cleft patients with or without a syndrome. I'll also mention real quickly the oral manifestations, but they will be later discussed by my colleague, the orthodontist. So we may have congenital missing permanent teeth and anomalies in the shape, enamel dysplasia, and a lack of saliva. The last two will bring to a higher rate of dental cavities, so the need of an orthodontist, dentist, and so on. So it is clear at this point that we need a multidisciplinary approach for these patients. Many specialists need to integrate to their expertise and follow the patient and treat. In Vicenza, we've been working like that for over 40 years. We have a multidisciplinary approach with all the specialists for all patients that refer to our unit, our cleft and craniofacial center. So not only syndromic, everybody. Let's start talking about the specific topic. What is a cleft lip and palate? A cleft lip and palate is a congenital malformation, which is characterized by a gap in the following structures: the lip, the alveolus, and the gum, and the palate, which is hard palate and soft palate. In the soft palate, we have the muscles. Very important. It's considered a rare disease, but it is not that rare, because in the world, every 3 minutes, a child is born with a cleft lip and palate. And it's a defect that happens during embryogenesis with various factors involved in it. So environmental and genetic, as said before. So the midphase starts developing around 4th, 7th week. We say that by the 12th week, it will be done. So we can have prenatal diagnostics with an ultrasound. There are various classifications on the type of cleft. What we need to remember is that this is a fissure, a gap that can involve different structures: the lip, the alveolus, right where the gums are and the teeth will grow, the hard palate behind the gums, and the soft palate with the muscles. So these are some examples, clinical examples. This is a unilateral cleft lip, just one side, a complete and an incomplete one. The incomplete doesn't interest the floor of the nose. This is a complete unilateral cleft lip and palate, but there are many different types of cleft because it can involve only the lip and the gums, gums and hard palate, or complete when it gets to the soft palate. We also mentioned we have bilateral cleft lip. So on both sides of the nose, interesting the lip, or complete going through the gums, the hard palate, and the soft palate. And as said before, only 10% of E.E.C patients will have an isolated cleft palate, which means a cleft that interests just the soft palate, the muscles, and the hard palate may or may be not interested 1/3, 2/3, or usually to the foramen incisive. So you may understand that there are different types of cleft. They're not only one form. It is depending on the structures involved. Treatment goals are more or less the same. Our treatment goals are craniofacial growth that has to be as normal as possible, normal swallowing and chewing, speech and hearing, and obviously psychological well-being. So we restore anatomy to achieve normal functions. So the best way to understand is to show you the clinical pathway we have in Vicenza, which starts very soon and goes on through adulthood. The first consultation is prenatal. Usually the couple contacts us with a morphology ultrasound scan, which shows a cleft lip. The palate usually is not seen. It's very rare to be sure about the prenatal diagnosis on the cleft palate. And yeah, also the hands can be diagnosed with the ultrasound. But please remember that the E.E.C. P63 can be detected earlier with DNA analysis too. So during this first consultation, the couple comes to our unit and has a consultation with the surgeon who will speak about the cleft and the protocol applied. The speech therapist will give some feeding advice and also will share the expertise and what will be the treatment protocol. There is a psychologist who will speak with the couple, and if needed, we might repeat an ultrasound with our OBGYN. The couple can decide if they can have the baby in our hospital or in other hospitals. So when the baby is born, within a week, few days after birth, if the baby is stable and there are no problems, we will have the first visit. So we'll come to our outpatient clinic and we will see the baby and confirm that diagnosis or not and see how the palate is involved. At this point, we will give an explanation of the treatment plan, a detailed explanation on what the baby will go through and the couple. And same day, the speech therapy and feeding consultation, because feeding is very important, cleft lip and palate. Most patients, most couples are afraid that they won't be able to feed their baby. Our primary treatment is based on early orthopedics, surgery, speech and hearing, facial growth, and dental occlusion. So on the same day the baby comes to our visit in the first a week, we will take a dental print and custom-made palate plate, which will help divide the oral cavity from the nasal cavity. This will help with feeding, tongue posture, and it will be a guide for jaw growth because it will prevent the tongue to push on the cleft sides on the palatal shelves. Then the speech therapist will take the couple and the baby and will try feeding with the plate and without the palate plate, and give the options and show them. It is very important to involve the parents, the caregivers, to stimulate oral motor functions and have a good interaction with the baby, because this way we have positive results. Surgical treatment then, once the baby grows at least 6 kilos, we can start with a surgical repair of the cleft and palate. So our first step is at 3 months, an early closure of the soft palate, which has muscles. That's very important for us. And then at 6 months, the lip and nose repair, 18 months hard palate, and later on, around 7 years, we will have an alveolar bone graft. Not all children undergo these procedures. So we start with a hospital admission. The baby usually stays for like 4 days. Immediately post-op, feeding will be reestablished, breastfeeding or bottle feeding, and there will be assistance by the speech therapist and psychologist during the stay to help them. The first step will be the closure of the palate. In this slide, you can see how the muscles are displaced and oriented vertically, and there is a gap. So we need to reestablish the continuum of the muscles. So at 3 months, we have the soft palate repair, which is a functional repair, reestablishing the muscles. Then later on, 6 months, we will go and close the lip. So we have, again, a unilateral lip or a bilateral cleft lip. So different techniques for the two. One is the Tennyson Randall, and the other one is the Manchester, both modified to restore also the nose. As you can see, feeding is reestablished later. Then at 18 months, it's the last surgical repair within the first year and a half, the hard palate. So the palate we close in 2 stages, and this is the last stage. And we're closing the gums as well. During this operation at admission, we have a ENT pre-op evaluation. And if needed in the same day, we will place ear tubes. So it's an integrated multidisciplinary approach. Here, the figure of the ENT comes into the picture. So this slide shows all the people involved: speech therapist, ENT, the orthodontologist, and obviously the surgeon. So we got to the 18 months, the closure of the hard palate. From now on, we will have a couple of years where we won't have any surgery, and it will just be a strict follow-up. So we will follow up on each and hearing. A kid that can hear well can probably repeat better the words and so on. So we have a yearly follow-up every year. They come on a Friday once a year, and the kid is seen from all the specialists: the surgeon, the speech therapist, the psychologist if needed, the ENT, and the pediatrician. At this point, we're also looking for any dental issues, and we might start with orthodontics. But there are some challenges with the E.E.C. These are 3 cases, 3 brothers of ectodermic dysplasia. Okay, so you see there are missing teeth. So here, obviously, we won't have any orthodontics. It's more a prosthodontic. We will need to consider making complete dentures for these children. Here we have 2 sisters with E.E.C. P63. And there are some missing teeth and a navel dysplasia. I mean, we have a worse quality of the teeth. So these are the challenges that we face with them. At around 9-11 years, according to the canine, we might have to perform an alveolar bone graft. This is the last procedure, surgical procedure, primary to close the cleft. So we will take some x-ray and see if we need to place a bone graft, and the bone can be either from the iliac crest of the patients or from a tissue bank. So we're getting to the end of the clinical pathway, and again, we will have some orthodontics, and that will, finish around 20 years of age. So this is a case that didn't need any secondary surgery. Okay, so just primary repair and orthodontics. Another case, bilateral cleft lip, primary repairs and orthodontics. But not all patients are the same. So we might have some challenges, and during growth, we might see a skeletal malocclusion. This is an E.E.C. P63 patient who had a dental malocclusion and skeletal. So you see the upper jaw is behind the lower jaw. So he performed a Lefort 1 advancement of the jaw, upper jaw, to give a dental stability and face harmony. We also had to add more bone because there was still an alveolar bone graft and a chin reduction just for harmony. Another challenge, these were 2 sisters that underwent cleft palate closure in another unit, and they came to our attention because they had a VPI. A VPI, it's a complication after palate surgery, which means that the palate is not moving well enough and not closing with the posterior wall of the pharynx. So this results in a nasal air leakage. So in our unit, what we do is a pharyngoplasty, this kind of pharyngoplasty. There are many different surgical treatments available for VPI, but this is our best choice because it's dynamic. It takes muscles from the posterior pillars and the wall of the pharynx, and it creates a sphincter that can improve speech. So in concluding, each patient is different. The goals are the same, but not every patient will undergo the same exact protocol. This means that treatment plan has to be tailored on patients' conditions and needs, and fundamental, the multidisciplinary approach, and a follow-up, because we need to see if there are any issues during time and intervene as soon as possible, and the importance of primary repair. So I thank you very much for your attention. And this is our contact info. I just wanted to say that during this difficult times, COVID pandemic, we are still working and you can contact us directly. Thank you.
Much, Dottoressa Piacentini, please stop the sharing of the screen. Well, we have receiving a really lots of questions, and we have choose 3 of those. For the others, you will receive, you patients will receive answer in our Facebook pages during the next days. So first question is from a mother. My baby needs surgery in December, and I'm anxious. Can you help me? I feel so small.
Yeah, well, in our center, we have the psychological work, and anytime we always say our patients that they can call us, they're free to call us, and we will have many appointments, as many as they need, to understand the condition, to understand the protocol, and to have the right support. So from the surgeon, the psychologist, the speech therapist, everybody. So just call us.
I think it's really important to have the psychology support for mothers and parents of a baby.
Well, we work in a way that every Friday we have the follow-up patients coming in and the first visits, and the psychologist is there with us. So in the same outpatient clinic is right there, and if we see there is an issue, we just call her and be like, okay, we have a couple or a patient that you need to see.
Thank you. Another question is important for you a collaboration between your center and the patient associations?
It is very important. Actually, Patient Association has working with us for over 40 years since the regional center was born, and it was very helpful. It was communication between patients and surgeons and other specialists, and we were always helping out each other, organizing even labs where we have fun together and have some speech therapy at the same time. It is fundamental.
Okay, thank you. The last question. How does maxillofacial surgery differ from plastic surgery in a patient with E.E.C syndrome?
Well, the main difference between a plastic surgeon and a maxillofacial surgeon is that we treat the bones, the jaws too, the skeletal. So we have a more complete view, because we will follow the patient not only with the surgical repair of the cleft, which also plastic surgeon can do, but we will continue following up on craniofacial growth, and then orthodontics and bone graft.
Thank you, Catherine. The director is connecting Professor Gracco, head of dentistry at the University Hospital of Padua, expert in E.E.C syndrome and genetic dental diseases. Antonio, give you the word.
Good morning, everybody. I'm Professor Antonio Gracco from University of Padua. My main topics is orthodontics. When we talk about patients with multiple teeth agenesis, the main problem we have is that we cannot do prosthodontic implants therapy in young patients. we need to wait until they have a total skeletal maturation, and so we are able to insert implants in the area where there are no teeth just only after 18, 20 years. So the problem that we have with young patients with agenesis is that we need to give the opportunity of having a good function and a good aesthetic during the first years and during adolescence. What we do in this time is we are able to construct a temporary prosthodontics devices that can give to the patient a good opportunity to have a social, normal life and a good function with their jaws. And the most important appliance that we can use in this situation is a temporary skeletal anchorage that gives us the opportunity of having artificial teeth in the place of the jaws where there are not the teeth. So I will have probably the opportunity to explain all these things in the future in the next events that you are going to organize. Thank you very much.
I would like to remind you that you can send your question by email or by writing them in the comment box below. Now the floor to Dr. De Stefani, colleague of Professor Gracco in the dentistry department of the Padua Hospital. Thank you, Alberto. Can you hear us?
Yeah.
Okay, that can go on. Oh, great.
Okay. Good morning. I would like to thank the organization committee for the great opportunity to present our work, our research here at this important meeting. Professor Gracco and I work at the University of Padua Dental Department, and we focus all our activity in orthodontics. The topics of this presentation is the treatment of the patient with the P63 mutation and its application in orthodontics. This mutation affected the teeth and its mutation. And the most important aspect in the treatment of the P63 condition is the hypodontia. The hypodontia is also known as teeth agenesis, and it is a congenital absence of at least one or more permanent teeth. This is a common dental anomaly. There are various definitions that are used to define the phenomenon of the congenital absence of teeth. We have the hypodontia or oligodontia, when there are more than 6 teeth agenesis, but we can also have a congenital missing teeth or dental agenesis. Anodontia is a rare condition when we have patients with completely absence of teeth. The diagnosis of hypodontia is a clinical and radiographic diagnosis. For example, in this patient, we have orthopanoramic radiograph when we can find 4 teeth absent in the upper arch and 5 congenital absence in the lower arch for a total of 9 teeth agenesis. In this patient, we have 4 teeth absence in the upper arch and 4 teeth absence in the lower arch. The literature says that the distribution of hypodontia is very common in the general population, and we can have the mutation of the genesis in 41% of the lower second premolar, followed by the upper lateral incisor, and followed by the upper second premolars. The agenesis are a very normal condition, and it can affect between 3 to 11% of the general population. But teeth agenesis is also associated with different genes mutation. So for this reason, the agenesis are a warning for the dentist to send the patient with more agenesis to other evaluation, for example, to a genetic evaluation. there is a strictly correlation between syndromic association with oligodontia. For example, we have many clinical syndrome that can affect the patient with tithagenesis. For example, the E.E.C syndrome. Okay. There are clinical characteristics that can affect the patient with more tithagenesis. So, for example, these patients are associated with a retrusive facial pattern, a reduced lower anterior facet, and in case where there are reduced proportion, this often result with an increased overbite of the patient. Okay, the clinical situation, the intraoral examination of the patient show reduced overbite and increase in the deep bite, and also from a radiographic point of view. In severe cases, there is often generalized spacing and retention of primary teeth, and this condition should be also treated by the dentist and by the orthodontist. And the generalized space is associated with microdontia, and the management of these spaces is a problem to solve with a multidisciplinary approach between orthodontics, restorative dentistry, and prosthodontic. So the clinical choice that we have to manage is if we can close the space or open the space for implant or prosthodontic rehabilitation. Another clinical condition is the retaining of the primary teeth until the adulthood in many patients. So the primary teeth is considered retented, and it can affect with posterior open bite. Or, for example, there is also an anterior open bite or deep bite with a collapse of the crestal bone. Now, I would like to introduce you different clinical cases and different problems, and all of them show a mutation of the genes associated with the E.E.C syndrome, but show different clinical patterns. I introduce you the first case, Luca, a 14-year-old male patient attended for an orthodontic consultation at our department. We published this clinical case last year in Dental Cadmos journal. His main complaint was an unpleasant smile and difficulty and mastication because of the consummation of the interior frontal teeth. The frontal facial analysis of the patient show a symmetric face, an unpleasant smile, an increased exposure of the buccal corridors, and an increased height of the lower third of the face. From a lateral point of view, the patient showed a maxillary and mandibular retrognathia with a pronounced sin. The intraoral examination showed an angle class 2 malocclusion with an increased overbite, microdontic lateral superior incisors, and reduced inferior deciduous, central, and lateral incisor. At the radiographic examination, it was detected the agenesis of 4 central and lateral incisors, 2 second premolars, 2 second molars, and all of the 4 third molars. The CBCT was analyzed using the Dolphin Imaging 3D software to obtain an analysis of the sagittal, coronal, and axial section, and a 3-dimensional reconstruction of the facial complex and airways volume. This exam was made in the most part of our orthodontic treatment. The family story of the patient was negative for any dental agenesis or any kind of genetic mutation. As a standard procedure, after a diagnosis of oligodontia, we required a genetic evaluation to obtain detailed information about the patient genotype. It was decided to do a specific diagnosis procedure of the WU&T10A gene that was found mutated. So the patient started his treatment with a bonding on the upper dental arch with an orthodontic fixed appliance, and after creating the space for microdontic lateral incisors, a conservative treatment was made on 4 superior incisors to make an aesthetic smile. In conclusion, this specific genetic analysis identified the presence of the variation of the WNT10A gene. After the analysis, the patient's mother and father reveal a heterozygous mutation of genotype of the same gene. The parents appear to be carriers of this gene mutation, and carriers of the mutation have a 50% of chance of being transmitted to the son. This means that the mutation is in heterozygous. Regarding the patient, its risk of transmitting each of the mutation to his children is completely 100%. And this condition is advised to be frequently consulted with genetic counseling during the reproductive age, together with the future partner, for an update of the knowledge that will become available over the time. The second case that I would like to show you is Lisa. Lisa is 15 years old, and she presents a normal facet, a retrograde profile, and the intraoral examination show many spaces linked with the agenesis and the absence of the lower incisor. From the lateral point of view, she presents a narrow arch with unilateral posterior crossbite on the left side and a non-correct occlusion. This also a radiographic evaluation from the Dolphin software, and the lateral radiograph and orthopanoramic radiograph show that Lisa presents 2 tetagenesis on the upper arch and 5 tetagenesis on the lower arch. The treatment consists in a previous phase of upper rapid palatal expander treatment to improve the arch of the patient, followed by a fixed orthodontic appliance in the lower arch, and then a provisional fixed appliance with the restoration of the frontal lower teeth. In the upper arch, after the expansion, a multi-bracket fixed appliance was performed in order to open the space and create the space for the successive rehabilitation of the lateral incisor. So when we have to open the space, we have to know how to manage the spaces. So we can have a provisional restoration applied, prosthesis applied on the lateral, the central incisor or the canine, or implant and prosthetic rehabilitation. For this patient, we decided to perform an implant surgery rehabilitation with the implant applied on the lateral incisor place, and then a fixed rehabilitation. Now I introduce you the third case, that is a very young patient. She is 5 years old. She came at our evaluation with many agenesis. She has the completely absence of the lower incisors, upper lateral incisors, and we decided to treat her with a provisional restoration with a provisional orthodontics fixed appliance with a lingual arch applied and bonding on the second lower decidus molar, and a rehabilitation of the lower incisors. The fourth case is the case of Gioia. She is 6 years old. She fixate, and she has a collapse of the upper arch with a characteristic retrusive profile and the aesthetic characteristic of a very thin upper lip. The intraoral examination showed the completely absence of the upper incisors and other titagenesis on the lower arch. This condition causes different problems to do with the speech, with eating, with his aesthetic and socialities at his school. We decided to treat her with a rapid palatal expander with an anterior crown applied on the appliances. Then, after the expansion, the layer mask was applied in order to stimulate the proportion of the upper arch. And then a successive treatment consisted in the application of mini screw on the palatal arch and the application with a provisional restoration. This is a new technology that we usually use in many orthodontic treatment with mini screw applied on palate. The application of this mini screw was performed by a digital program that we use to apply the mini screw on the palate, and it is used for palatal anchorage for different devices. So the software is used to apply the two screw and to perform the different appliances. The last case that I will show you is Alessio. He came at our evaluation at the age of 12 years old because it is this condition. It has the absence of many teeth. It has very different agenesis. He presents only 6 teeth on the upper arch and only 5 teeth on the lower arch. And we decided to treat it with removable prosthodontic rehabilitation on the lower arch until the adulthood, where he can do fixed prosthodontic appliances supported by implant. And in the upper arch, we performed the application of mini screw, 4 mini screw in the palate, and the provisional restoration support applied on this device. And this is the photograph of the orthodontic treatment that we performed with the provisional restoration applied to the devices. In conclusion of this presentation, the patient with hypodontia should be considered to genetic evaluation for possible mutation. The dental practitioner can be sentinels and patients that present different genesis, patient that is also healthy and general patient with more than 6 titagenesis should be sent to genetic evaluation. There is a multidisciplinary approach between orthodontics and the other dental specialties. And our objective in this patient is a proper occlusion for chewing, for aesthetic, for speech, and for sociability. New technology as the application of mini screw in the palate is a gold standard for improving the treatment quality. And thank you for your kind attention.
Thank you for your presentation, Prof. Stephanie. And we have receiving really so much questions also for you, for your presentation. And Roberta, please, can you read some?
Yes. The first one, in this period with COVID-19, how you manage appointments and emergency in your department?
Yes, of course. In this year, we have reduced the appointment for the patient, but we use the internet,
And in case of emergency, if we have an emergency and odontologic emergency, can we come in your department?
Yeah, we have some emergency, and we can continue to visit and treat the patient that present an emergency, but we use a different platform as Zoom or Telegram or other software to visit the patient from distance, and we have to decide if the patient that come to our department or we can visit him from home.
Okay. And the last one, how are the cleft palate and bone fragility an obstacle in dental practice?
The cleft is an aspect that we have to consider in the treatment of the patient. And when we have some cleft, we have to decide to manage the space, and we cannot move easily the teeth inside the cleft area. So if we have some space that caused by the cleft, we have to manage it with other restoration until the adulthood of the patient was present. So, for example, the application of mini screw and prosthodontic rehabilitation, or Marylander bridge supported by the other dental, the other tooth. So we have to consider the cleft in the treatment of the patients.
Thank you. The other questions we receive an answer in our Facebook pages during the next days. So we left the word to the last one presentation of this meeting, that is Dr. Drago from the University Hospital of Padua.
Good evening, everyone. My name is Gianpaolo Drago, and this is my colleague Dr. Anna Scarpis, and we work together at the Dental Clinic of Padova with the prosthetic and restorative team. First of all, I would like to thank Professor Stellini, Director of the Dental Clinic in Padova, who gives us the opportunity to collaborate with the orthodontic team of Professor Gracco to finalize and complete their orthodontic cases in patients with congenital and acquired aesthetic deficiencies. I also thank Giulia Volpato and Cristina Boltonella, who invited us today. With Anna, we share the opinion that for our patients, especially with syndromic situations, it is important not only the correction of their malocclusion and the reinstatement of the oral functions, as we have seen before, but also a beautiful smile, and why not a perfect smile. And we think that this is an important aspect in well-being of everyone from a young age. Therefore, the key points we always need to have on focus are a multidisciplinary team collaborating for the best result achievable, an early intervention to restore the patient's smile as soon as possible, even with temporary solutions. We should not stick to preformed aesthetic models where we have to aim at an individual aesthetic result, enhancing the patient's own characteristics. We see these kind of cases every day, even during the hard times of coronavirus, because we think that this is a priority for patients to restore the aesthetic of their smile, and we consider their rehabilitation our professional mission. Thank you.
Okay, hi everyone. Good evening. I'm Anna Scarpis, and it's a big pleasure to be here today. With Dr. Drago, I started to see and restore the smile of patients with disorders or syndromes like E.E.C, whose clinical features include multiple agenesis, shape or size anomalies, and other dental anomalies like discolorations and so on. We all know that this kind of situations may have a big impact on a child's social life as soon as he starts attending the primary school, but also the nursery school, and they can have big psychological consequences. For these reasons, it must be a priority for us to restore the smile, not only from a functional point of view, but also from an aesthetic point of view, even if restoring it at a young age means necessarily doing it with temporary solutions. Our patients are always followed by a multidisciplinary team, and we usually first meet them during their orthodontic treatment, so we can share with the orthodontist the treatment plan and the best position for the teeth for a correct prosthetic and restorative rehabilitation. Cooperation and coordination is essential because we need to restore the teeth as soon as the orthodontic device is removed, so the teeth don't change the position obtained. So during our first visit, it is important for us to get the information to evaluate, according to the age of the patient and the specific pathology, the more suitable kind of penalization. So we collect the patient's records, X-rays, we take pictures, we take the impression of the arches, sometimes with the aid of a facial arch, which is necessary to position the dental cuts in their actual position. And with all of this information, we realize what is called a wax-up that you can see in the picture. That is simply the simulation of the final result, with the missing teeth replaced or the misshapen teeth restored. And here you can see that the diastema, the central diastema has been closed and the shape of the teeth has been changed. But what are the principles at the origin of the sensation that influence our aesthetic judgment and which direct our clinical work? Are there objective elements that influence our sensation? Is it just the symmetry of the teeth or the white of the teeth? We are, and the patients are often oriented toward preformed aesthetic models, but the individual aesthetic reality cannot and should not be limited to some kind of ideal model, cut and pasted on every single patient. A smile is beautiful when it expresses a perfect balance between elements. And so every time we see a different patient, we need to search for their individual aesthetic, and this is how we do. In the first visit, after analyzing the face of the patient, dividing it in vertical and horizontal parts, our focus is obviously the smile. So we observe the shape of the length and the length of the lips, the relation with the teeth, how much the patient shows the teeth when he smiles, the shape of the teeth. Here you can see that the incisors can be classified in triangles, squares, and circles. And there are other aesthetic criteria that we try to respect when we plan an aesthetic rehabilitation. In the dental art, there is always a structure, an order, and if a single element does not respect the structure in which is included, it would appear out of place. So here you can see how usually the edges of the central incisors are a little lower than the edges of the lateral incisors. Also, the gingival parabolas are not on the same level. The parabola of the central incisor and the parabola of the canine here, you can see that are 1 millimeter higher than the parabola of the lateral incisor. All the edge of the teeth here you can see they follow an ideal parabola pointing up. The longitudinal axes are oriented in a certain way. There is also a proportion between the height of the teeth and the width of the central incisors. The width is usually the 80% of the height. And if we see a smile from a frontal point of view, we can see that the transversal diameters have a particular relationship between them. Also, the transitional line here red, and they are the lines where the light is reflected, contribute to define a specific structure. They are parallel in each side and converging here to the midline. Moreover, the shape of the black in the interproximal spaces have the shape of triangles open toward the bottom. From the midline here to the distal part of the arch, the triangles become wider, and this is another structure we need to respect. So contouring lines, transitional lines, incisal lines are the main aspect we try to achieve when we plan a rehabilitation. And on these fundamentals, we realize, or the technician realizes, the wax-up. In the simplest case, we need to correct just the shape or close diastemas between teeth. Like in this case, from the wax-up, we realize a silicone palatal key that helps us to give the correct shape to the teeth, but now we're gonna see it. This is the case of a patient with conoid incisors, which we can find in cleft palate and lips or in ectodermal dysplasia, where we often have a conoid tooth and the contralateral missing. But here, in this case, the lateral incisors are both in place. There are some genes involved, but the cause of their alteration is not clear yet. So after choosing the correct color shade, we place the rubber dam here in light blue and to isolate the teeth. We always try to be as much conservative as possible because we work with young patients and we need to maintain the dental structure intact. So we usually don't remove any dental part nor smooth the teeth, but we simply roughen the dental surface. Here you can see the position of the silicone palatal key on which we arrange the composite, and here the final results, which shows a big aesthetic improvement. You can see the start here, this one, and the beautiful result. In case of multiple agenesis, the situation is a little more complicated, and a clear treatment plan is essential the close collaboration between the orthodontic team and the prosthodontic team. On the basis of the case study, sometimes the spaces are closed, and sometimes the spaces of the missing teeth need to be preserved until the patient is old enough to replace the missing teeth with implants. We have many different solutions to maintain temporarily the spaces in the frontal area, but we're going to see just a couple of them. This is a case of a 5-year-old child with oligodontia. Oligodontia is a number anomaly where more than 6 teeth are missing. In this case, the patient's orthopantomography showed just 12 permanent teeth, and the patient's mom had the same anomaly. The patient's parents asked for the less invasive rehabilitation approach available for this condition. So since the first visit, the patient has consistently been followed by a multidisciplinary team consisting in an orthodontist and a prosthetic and restorative specialist. Before undertaking any treatment, we requested a genetic counseling to see if his oligodontia was related to other more complex clinical situations like ectodermal dysplasia, but it turned out that he had isolated oligodontia. When we see a patient with multiple agenesis, we always need to request a genetic counseling. So after the case study made by the interdisciplinary team, the patient underwent an orthodontic treatment. So he had his palate expanded, and after that he was asked to use a Delaire mask to improve the growth of the midface. And later the patient underwent a fixed orthodontic treatment to align the upper incisors. After the treatment, we proceeded with the replacement of the missing teeth. A lower deciduous central incisor was extracted, this one, because it was mobile. And the therapeutic decisions has been made considering all the options, but in agreement with the parents, we choose a rehabilitation with adhesive bridges. Here you can see in the dental cast. To replace the lower extractor incisors and the upper canines. Composite overlays here were applied on the posterior teeth to have a stable occlusion, and the case was finalized with the restorative stage. A camouflage with the adhesive direct restorations was performed on patients' frontal teeth to improve the aesthetic of the smile, and the approach was very conservative. Only the outer non-prismatic layer enamel was removed, and the aesthetic evaluation was based upon the golden ratio through the use of the golden compass, comparing the mesiodistal diameters of the teeth. So the orthodontic treatment has successfully solved the patient's malocclusion and aligned the existing teeth, creating the right spaces to replace the missing teeth. And then a stable and functional occlusion was obtained with the application of the composite onlays on existing permanent teeth. And the final aesthetic result was reached with the adhesive restorative treatment. So we adopted an interdisciplinary approach, which resulted in an aesthetic and functional improvement without invasive therapies. when the patient grows up, he will replace the missing teeth with the implants. But we still need to finalize this case. Other temporary solutions may be temporary teeth applied on tats, also called mini screw. Here you can see a mini screw and the teeth, the tooth replaced. Another option are prosthetic teeth included in transparent masks, and this is a solution, practical solution for patients rehabilitated with Maryland who occasionally can debond. So the patient has an emergency solution. Therefore, the key points are always we always need to have on focus are a multidisciplinary team collaborating for the best result achievable, an early intervention to restore the patient's smile as soon as possible, even with a temporary solution. And we know that we should not stick to preformed aesthetic models, but we have to aim at an individual aesthetic result, enhancing the patient's own characteristic. Thank you. And this is the presentation. And we want to say that also in these times of coronavirus, we are here in the dental clinic of Padova, and even with a lot of face masks and some other precaution, we can see the patients here in Padova. Thank you.
Allora, siamo arrivati alla fine di questa giornata fantastica, un po' faticosa anche, sì, ma perché è tutto nuovo, perché abbiamo portato i nostri esperti e le vostre domande in un webinar dedicato, e cioè in un momento condiviso in rete che però ci ha visti tutti insieme. Quindi grazie ovviamente alle mie preziose e presenti, sempre presenti, Giulia Volpato, vicepresidente dell'associazione P63 Sindrome E.E.C International, e a Roberta Bresciani, la nostra responsabile non soltanto da un punto di vista organizzativo, ma anche proprio per gli obiettivi. Ma il nostro staff non è solo questo, come sapete c'è un folto numero di persone, di giovani e di volontari che tutti i giorni lavorano con noi per valorizzare tutto quello che cerchiamo di darvi e per non solo darvi risposte, ma anche veramente una qualità di vita. Quindi grazie a tutti, ci vediamo domani continuerà i nostri ricerche nei confronti con l'attenzione alla persona al centro, quindi un aspetto sociale. E prima di chiudere ovviamente i saluti vengono rivolti in lingua inglese da Giulia e da Roberta.
So we are arriving at the end of this day, this webinar dedicated to P63 gene and E.E.C syndrome. It is the first time by a webinar for us, and thank you for your participation. We have received really so much questions, and we will answer to all your needs by our Facebook pages during the next days. Thank you to Cristina Morcinella, our president. I'm Giulia Volpato, the vice president, and Roberta Bresciani, our pharmacist and responsible of the goals of our association. We see you, we give you the welcome for the tomorrow webinar by Facebook and YouTube networks, and we will talk about the social aspect dedicated to people and persons with rare diseases. To finish our day today, we have a special guest that is really important for us. But at the end, a really big thanks to all our staff, our volunteers, our networks, and the organization of this webinar.
Thank you very much.
This is it, boys. This is war. What are we waiting for? Why don't we break the rules already? I was never one to believe the hype. Say that for the black and white. Try twice as hard and a map is like, but here they come again to jack my style. That's alright. I found a martyr in my bed tonight. Stops my bones from wandering. Just why? For this, I miss my mom and dad for this. No, when I see stars, when I see stars, that's all they are. When I hear songs, they sound like the swans. So come on, well, don't see guys, daddy's on 5 minutes in and I'm bored here. 10 years of this, I'm not sure if anybody understands. This one is not for the folks at home. Sorry to leave, but I had to go. Who the fuck wants to die alone? All dried up in the desert sun. My heart's breaking for my sister and the calm that she called love. And then I look into my nephew's eyes. Man, you wouldn't believe the most amazing things they can come from. If you believe in love tonight, I'm gonna show you one more time. If you believe and let it out, no need to worry, there's no doubt. If you believe, if you believe.
Io ringrazio tantissimo per l'invito che ho avuto e per me è un grande onore far parte di questo gruppo.
The tension becomes more than I can bear. Then you wrap your arms around me and I feel your every move. This feeling could now lead us anywhere. Now we'll leave the world behind us. This moment we will share.